Hello everybody, my name is Kagalwala Taha Murtaza. Today I'm going to speak about inguinal hernias and their treatment. So a hernia, what is it? It's a general term referring to protrusion of a tissue through the wall of a cavity in which it is normally contained. Common organs which are prone to herniation are omentum and small intestine usually. Rarely you can also find the appendix, ovary with fallopian tubes, urinary bladder, sigmoid colon, cecum, etc. Inguinal hernia. These are hernias which are outpouchings through the weak areas of the anterior abdominal wall. There are two types, direct and indirect. So indirect or oblique inguinal hernia, these are more common at all ages and sexes. So here, as the name suggests, the indirect hernia takes an indirect course through the anterior abdominal wall by leaving the abdominal cavity lateral to the inferior epigastric vessel. It traverses the deep inguinal ring, inguinal canal, and the superficial inguinal ring. It is covered by all three layers of the spermatic cord, which is the external spermatic fascia, cremasteric fascia, and internal spermatic fascia. The hernial sac over here is the remnants of the processus vaginalis, which normally obliterates except for the part which forms the tunica vaginalis. If the entire stalk persists, this hernia is said to be complete and enters into the scrotum. Now, since the scrotum and the layers with it are outpouchings of the anterior abdominal wall, these type of hernias are about 20 times more common in males than in females. The labia majora in the females, which are homologous to the scrotum in males, they contain mostly fat, making the weak area very small, and so herniation over here is usually very rare. There are two types of indirect inguinal hernia, congenital and acquired. So although congenital means present at birth, the word congenital over here simply means that the potential for congenital inguinal hernia persists because of the patent processus vaginalis or some of its remains, and the herniation occurs later in life following lifting, pushing, coughing, or straining the abdominal wall. Next is direct inguinal hernia. This hernia, it protrudes anteriorly through the posterior wall of inguinal canal, and it leaves the abdominal cavity medial to the inferior epigastric vessel. It passes through the inferior part of the inguinal triangle, or also called as the Hasselbalch's triangle, seen in the right half of the slide. This triangle is in the posterior wall of inguinal canal, which is formed by only the transversalis fascia, and hence it becomes a weak spot of anterior abdominal wall. The another cause of this type of hernia is also the shutter action of the muscles. This is the obliteration of the gap which is present between the conjoint tendon and the inguinal ligament, where the muscles of anterior abdominal wall contract during either coughing or straining. The hernial sac over here is composed of peritoneum. Uh, the hernia reaches the superficial inguinal ring without passing through the deep inguinal ring, and it emerges superior and inferior to the spermatic cord. This type of hernia is less common and usually occurs in men after 40 years due to the weakening of the muscle of anterior abdominal wall, thus reducing the shutter action of those muscles. Next is treatment. So the basic principle over here is that since both the direct and indirect inguinal hernias, there is some yielding and relaxation of the transversus abdominis, aponeurosis, and the transversalis fascia. The principle over here is that there should be restoration of muscular aponeurotic continuity in the deep layer of the groin, which is formed by the transversus abdominis layer. And what is done to the more superficial layer, which is the external oblique, is not of that importance over here. Next is operative treatment of indirect inguinal hernia. So indications, as you can see on the slide, is all the indirect inguinal hernias must be treated unless they fall under certain contraindications like the age or the poor physical condition of the patient. Anesthesia is of three types. The most recommended one is local infiltrative anesthesia, but in cases of obstruction, general anesthesia with an endotracheal tube is given. And in children with or anxious adults, inhalation anesthesia is given. The patient lies down in a supine position with a pillow under their knees, which helps the groin to relax. Then a lower oblique laparotomy is performed where the incision is made 2 to 3 cm above and parallel the upper parts or inguinal ligament from the anterior superior iliac spine to the pubic spine. A more cosmetic incision is made along the line of the skin grease. Here, the superficial epigastric and the external pudendal vein are first clamped and tied. The incision is made till the external oblique muscle. The fat over it is clean and the superficial ring is identified. Margins of the external oblique is freed and another small incision is made. This incision passes through the internal oblique The cremasteric fibers are then grasped by toothed forceps and divided. Then the contents of the inguinal canal are first identified, and the sac is opened carefully, and its contents are replaced within the peritoneal cavity. The sac is then forced with either a blunt or a sharp dissection. Then comes closure. So for closure, various methods could be used, but usually in large and recurrent hernias of older persons, partial or complete transplantation of the cord is made along with narrowing of deep inguinal ring. Next is the operative treatment of direct inguinal hernia. Here, the indication is mainly for the McVay primary tissue repair. Uh, the McVay primary tissue repair is mainly done in the frequent recurrence of direct inguinal hernia, or when a previous operation mesh is needed to be removed, or when the femoral space needs to be obliterated. Anesthesia is the same as it was last time, and the position is again in the supine position with a pillow under their knees. The McVay procedure, as seen in the picture, they are the muscular tendinous structures, which is the transversalis fascia and the aponeurosis of transverse abdominis muscle. They are attached to the Cooper's ligament and the lacunar ligament medially and the inguinal ligament laterally. To accomplish this, the conjoint tendon is retracted upward, the spermatic cord is moved downward, and the transversalis fascia, which is adjacent to the pubic spine, is freed. In order to visualize the Cooper's ligament, then 3 to 5 interrupted silk sutures are put. In obese individuals, however, it is a very difficult exposure in this location, so care is taken to avoid injury to iliac vessels. However, there are many more approaches towards the inguinal hernias, and all of them are either aimed to strengthen the anterior or the posterior wall of the inguinal canal, first of which is the Bassini's method. And Bassini's method is to build the posterior wall of the inguinal canal. Over here, suturing of the internal oblique, transverse abdominis, and the rectus abdominis muscles are done to the inguinal ligament. Next is the Girard's method. Girard's method is made for the anterior wall of inguinal canal strengthening. In the Girard's method, the inferior edges of the transverse abdominis muscle, internal oblique muscle, they are sutured along with the inguinal ligament, and the flap formation is made on the aponeurosis of the external oblique. Next is Pasokokotsuki's method. This is performed by stitching the aponeurosis and the muscles together. After penetrating the aponeurosis and the muscle with a needle, the needle also approaches the inguinal ligament. Next is the Schulde's method. In this, the lateral border of transversalis fascia is stitched to the lower surface of rectus sheath by making an uninterrupted suture. In Schulde's method, the suture is continued, connecting both ends of the transversalis fascia to the deep inguinal ring, and then the suture is turned in the opposite direction to suture the medial border of transversalis fascia to inguinal ligament. Lastly, we have the Lichtenstein's method. Over here, a polypropylene mesh is used. In this method, for a direct hernia, the transversalis fascia is dissected above the hernial sac and reduced. For oblique hernia, after the excision of hernial sac, the deep inguinal ring is restored and then the transversalis fascia is sutured. In this, a polypropylene mesh is used for plastic repair of hernial ring. It is implanted in the spermatic cord and fixed by interrupted sutures to the inguinal ligament. Next, the superior edge of the mesh is stitched by interrupted sutures to the internal oblique muscle, and the inferior edge of the mesh is fixed by 2 to 3 stitches to the pubic tubercle together with the superior pubic ligament to prevent formation of the femoral hernia. That is it for inguinal hernias. Thank you.